surgical oncology nurses that are trained in post-operative care, preoperative care, and for nurses that are in the OR, perioperative nursing, as well as oncology. So they have to be competent not only in surgical care, but in oncology care too. The surgical oncology nurse needs to understand what chemotherapies and treatments, radiation therapy, anything like that has been done with that patient, because that will certainly impact that patient's outcome, but also to understand the whole surgical process.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we're talking with Lisa Parks, inpatient nurse practitioner of hepatobiliary surgery for the James Cancer Hospital and Solove Research Institute, Division of Surgical Oncology at The Ohio State University Wexner Medical Center, about the role of surgery for patients with cancer. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Lisa.
Thank you for giving me the opportunity to talk about the area that I'm most passionate about in oncology.
Well, that's what we love to hear. We always enjoy having guests who we can just hear the passion about the work that they do. Let's focus our conversation today on the phases of surgery throughout the cancer journey. The first of which happens to be before a patient even enters an operating room. Can you tell us about prehabilitation for surgery and its benefits for patients with cancer?
Prehabilitation for surgery is probably one of the most underutilized areas of the surgical process. The goal of prehabilitation is to initiate coordinated preoperative optimized strategies. During the patient's preoperative assessment by the oncology nurse in the clinic, as well as the provider, risk factors are identified that can be addressed for a better surgical outcome. There are 3 phases to the prehabilitation process. The first is screening and assessment. And there's a wide variety of screening tools, including nutritional screening tools, frailty screening tools, and mobility screening tools that can be utilized. The second phase are interventions that are based after the screening is completed on the patient's individualized needs. And then there is the post-treatment evaluation after prehabilitation is completed. Just because a patient completes the prehabilitation process doesn't necessarily mean that they are going to proceed with surgery. If the outcome from the prehabilitation interventions still do not optimize the patient for surgery, a lot of times the patient is steered more toward medical interventions. There are risk factors that can be modified for better surgical outcomes. One of the common risk factors is cigarette smoking. Cigarette smoking is associated with venous thrombosis, surgical site infections, pulmonary and cardiovascular complication. Incision healing is impaired when peripheral vasculature is altered with cigarette smoking. Even stopping smoking for a short time may decrease the complications associated with smoking cigarettes. Oncology nurses should refer these patients to providers for smoking cessation programs. Another risk factor addressed is malnutrition. This is very common among the frail elderly and cancer patients. Even patients that appear to be obese when nutritional labs are drawn, a lot of times are seen to be malnourished. Labs such as prealbumin, albumin, and BMI are assessed. And as I mentioned earlier, there are numerous malnutrition screening tools that can be utilized to assess malnutrition. Preoperative nutritional interventions have been shown to reduce surgical site infections by 20 to 40%. So a lot of patients are educated on a high protein diet with protein supplements. And the best effect of these supplements is initiating them 7 to 10 days prior to surgery. Also, if patients are, due to their cancer, unable to eat, these patients will be started on parenteral or enteral nutritional supplements. The next risk factor that can be addressed is, in general, poor physical fitness. And this is a predictor of a poor surgical outcomes. Adults that are over the age of 60 and otherwise healthy can still benefit from increased exercise capacity. This oftentimes can include referrals to physical and occupational therapy, who can give them daily exercises. Walking is often a great physical fitness exercise that patients can perform prior to surgery. And the last modifiable risk factor is alcohol use. It takes about 6 weeks of alcohol abstinence to decrease the effects that alcohol can have negatively on the surgical process. What we normally see with patients who do not stop using alcohol is delirium within the hospital post-op setting.
Thank you for giving us that list of different risks that prehabilitation can definitely help with for patients who are going to be having surgery as part of their cancer journey. With all of those risks that you went over, can you maybe give us some examples of surgeries where prehabilitation would benefit the patient? So maybe that's based off of a diagnosis or location of the cancer that has been discovered.
Really, any solid tumor patient that is having an oncological surgery can benefit from prehabilitation. It really depends on their overall assessment preoperatively. So there's not any list of surgeries that you would want the patient to complete prehabilitation, but it depends on their preoperative assessment and certainly any lengthy surgery that's going to require the patient to be under anesthesia for a prolonged time. Patient would certainly benefit from being optimized prior to a surgical procedure.
So you mentioned when you were talking about some of the risks, and specifically, I remember you talking about with nutrition that they might have to be started on some of those supplements or different types of nutrition about 7 days before surgery would happen. Can you maybe talk about all of this whole prehabilitation work that is done with patients? When does that start, or how soon does that need to start prior to a patient having the surgery?
So when a patient is initially seen by a surgical oncologist in a pre-op setting, all of these assessments are completed by the oncology nurse as well as the advanced practice oncology nurse for the patient. And in order for the patient to go through the surgical process, prehabilitation is started immediately after that initial visit. The patient will be brought back in and reassessed periodically while going through prehabilitation. For instance, if they're undergoing physical therapy or occupational therapy, they'll be brought back in for the provider to reassess to see if they're making improvements. The same for nutrition and things like that. It's an ongoing assessment to try to optimize the patient before they ever come to a surgical center to have surgery.
I think that's really helpful to know because so many of our listeners, might be in a practice or in a physician's office where that initial diagnosis is done prior to surgery and prior to their patient maybe being sent to a larger center. So it's good for our listeners to know and understand kind of how this process works.
Stephanie, that is a great point. As I do work in a tertiary referral center, often people think they're being sent here to have their surgery. But even if they come into the hospital as a transfer in and are not seen in our outpatient clinics, we still are doing those same assessments. Our goal in surgical oncology is, of course, to treat the cancer for a cure, but to do it in a safe manner that the patient is able to recover and resume their normal activities of daily living that they had before their surgery. So for some of those patients, and for example, somebody who has a tumor that's obstructing their GI tract and they can no longer eat or drink well, those patients may be started on parenteral nutrition, TPN, and they may be discharged from the hospital on TPN until their nutrition labs are in a range that we can ensure that they won't have an anastomonic breakdown or a surgical site infection.
That's a great example. Thank you so much for that. So, in mentioning those nurses that are in those maybe smaller settings, or even the nurses that are where you work, or in the larger settings who are on those units where the patients get admitted prior to surgery, where some of this prehabilitation might take place, how can nurses help patients overcome some of the challenges that they might be faced with in this prehabilitation phase?
Well, I think two of the greatest challenges that I hear from nurses are family support. The family needs to understand the whole process of prehabilitation and the fact that the patient is not going to come to harm by waiting a couple weeks to optimize themselves to undergo a major cancer operation, and to make sure that they're providing transportation and assisting their family member if they need to go to outpatient physical therapy, occupational therapy, pulmonary rehab, things like that, that the provider may, based on assessment, refer these preoperative candidates for.
I'm so glad you mentioned that because I really do think that not only patients, but family members really don't understand when their family member receives a cancer diagnosis. And especially if it's something that you mentioned, an obstruction or that maybe it's a visible tumor and they know that there has to be surgery, but now the surgical team is saying, well, you're not healthy enough to have the surgery, so you're going to have to wait. The anxiety that family members have for their loved one that just received this diagnosis. So that's such a good way to help these nurses know how to talk to these family members and explain that this is actually going to help them in the long run do so much better with the surgery and what those outcomes might be. So that's a great example of that. Now let's move on to how surgery is actually used in a cancer diagnosis. Can you talk to us maybe about the different types of surgery that might be used with someone?
Yes. And there are different types. And I think sometimes that's very difficult for people to understand, because when everyone thinks of surgery, they think about cutting out a tumor and then the cancer's gone. But a lot of times that's not what the goal of the surgery is. One of the types of surgeries that you may see performed in a cancer center is basically diagnostic surgery. A lot of times what they're trying to do is to do a laparoscopic or minimally invasive surgery where a camera is inserted into the chest or abdomen, and they're looking for metastatic disease, trying to plan the surgical procedure. But obviously, if there's metastatic disease, a surgery is not going to be beneficial for those patients, because once that cancer has gotten out of the local lymph node bed and spread into other areas, even removing that initial cancer will not benefit the patient at all in their cancer treatment. The staging or diagnostic laparoscopy will give that information to the surgical oncologist. Also, even if they don't see metastatic disease, it allows the surgical oncologist to better define any kind of vascular involvement that the tumor has with major blood vessels. Sometimes, if that is the case, surgery can still continue, but it may require reconstruction, various blood vessels that may sometimes require a vascular surgeon or somebody to assist a surgical oncologist. And then the other thing that we see is palliative surgery. And this, a lot of times, we will see with malignant bowel obstructions that are due to diffuse metastatic disease. And in this case, what we're trying to do is give the patient the best quality of life toward the end of their life that they can have on this cancer journey. And obviously, if their GI tract is obstructed, we need some way for the feces to be able to come out of the body. So these people may have a ostomy created to relieve the bowel obstruction. It obviously, there is no tumor, there's no cancer that's resected at this point in time. It's totally to palliate the patient's symptoms at this point in time. And then obviously, the last is a curative surgery. Now, I think that's the goal of any surgical oncologist. But again, given the disease presentation at the time, that may not always be possible. But in a curative surgery, the patient's solid tumor is removed as well as surrounding lymph nodes. And those are analyzed for any metastatic disease within the lymph nodes. Usually, if there's metastatic disease, the patient will be referred on for chemotherapy at some point in time. But those are basically the three types of surgeries that you may see.
Okay, then Lisa, let's talk about palliative surgery. How is that used during a patient's journey with cancer?
Well, that is usually used in a situation where the patient has diffuse metastatic disease. A lot of times these patients can be undergoing chemotherapy, and sometimes the chemotherapy can cause a bowel perforation, or, you have somebody who has a completely obstructed GI tract. The surgeries there are meant to treat the problem that the patient presents with, like a bowel perforation. The patient may end up with a bowel resection to get rid of that area that has a hole in the bowel and to connect the good parts of the bowel back. And again, in the case where somebody has an obstructed bowel, we may need to create an ostomy to relieve GI contents that the patient accumulates in the GI tract. Oftentimes, we also may place what we call a percutaneous endoscopic gastric tube, or a PEG tube. And that tube is a lot of times for people who have an obstruction near the stomach and are hospitalized with a nasogastric tube. And in order to send these patients to hospice and to be able to send them out without the NG tube, we will take them to surgery and place a tube which can be opened up by the patient and hospice and drain out the gastric contents so that they are not vomiting and nauseated, so that they have a better quality of life at the end of their life.
Thank you. I think, again, such important points that you are giving us today. And just to be able to understand, that even near the end of life with patients that have a cancer diagnosis, surgery may be an important part for them to have some quality at that time. That might not be something that folks understand. And so it's really good to see what those reasons are that you might have to do something like that.
I agree, Stephanie. Like I said, I think that people always think of surgery as being curative, but a lot of times some of the procedures that we do are to sustain a quality of life for the patient at the end of their life.
Exactly. So, what are some risks that would be associated with surgical interventions for patients with cancer?
Well, since heart disease is the number one killer of Americans, certainly a cardiovascular assessment needs to be performed prior to surgery. That will include looking at the patient's past medical history. We're looking for any kind of arrhythmias, including an insertion of a pacemaker, history of pulmonary embolism or deep venous thrombosis, heart failure. A lot of times patients will be referred to a cardiologist for evaluation who may complete other cardiac testing like a cardiac stress test or a cardiac echo. As far as endocrinology, we have found a lot on just basic preoperative lab work. Patients a lot of times have undiagnosed diabetes. So if we do notice elevated glucose, we'll probably send a hemoglobin A1C on these patients. And if they are undiagnosed diabetes, we try to get them in to see an endocrinologist because, again, high glucose is one of the main causes for surgical site infection. So we want to get that controlled prior to surgery. We do also see pregnant patients that unfortunately have developed cancer. Those patients, we work very closely with their OBGYN, having them monitored pre-op, during the surgery, and then evaluated post-op by the OBGYNs. And then with morbid obesity, we often see a lot of pulmonary complications. And that's because a lot of these patients have obstructive sleep apnea and use CPAP, or some who choose to be diagnosed and not use CPAP. So then we're very concerned post-op about their respiratory function. A lot of times it requires a lot of intense pulmonary toilet from the oncology bedside nurse as well as a respiratory therapist.
Thank you. Some good things for those nurses who are with the patients early in the diagnosis part of the journey and kind of preparing them for what those steps might be before they have to have surgery. The next thing I want to talk to you about is it's interesting as the whole oncology world changes and there are new treatments, new therapies that come up every year and so many new therapies. It is that way with surgery also, with using robotic surgery and things like that. So that's what I want to talk about now. How are robotic and robotic assisted surgeries used for patients with cancer?
Robotic surgery is very interesting in that it was developed many years ago, actually to do like brain biopsies and things like that, but not really mainstream. The first minimally invasive surgeries that we started to see utilized was in the 1990s, and that was your laparoscopic surgery, the one where you're sticking the camera in and then you have arms that you use the camera to kind of visualize your surgical field. That has kind of still been used more in the diagnostic situation. But we're seeing robotic surgery really coming into just about every different kind of solid tumor surgery that you can see, from lung cancer to ear, nose, and throat cancers to certainly GI cancers. And the reason being is that there is a lot more control by the surgical oncologist. With a robot, there is 3D imaging, and you're able to really magnify the surgical field. Also, you're able with the robotic arms to get deep into areas that are otherwise very difficult, even in an open surgery, to be able to access. So you're getting better access within that surgical field. The robot filters out tremors, not saying that the surgeons are shaky or shaking, but certainly it just filters out anything that might jar the arms within the patient. And then also there is minimized trauma with the robot in that they're able to perform a very complex surgery with very small trocar or puncture sites where the surgical instruments went in, and usually a very minimal incision, so that you're getting a faster recovery for the patient just based on the fact that they don't have these large open incisions. Pain control, I believe, is better. And again, because we're minimizing large surface areas that have been cut and retracted during a surgical procedure.
Thank you. That is just a fascinating area for surgeries alone, and just to see how that has progressed over the years and how that can be used is just amazing. You were talking about some of those ways that it's changed from, those more traditional open surgeries to being able to use the robotic surgeries now. Are there any specific cancer diagnosis where robotic or robotic assisted surgeries are recommended now versus over the traditional types of surgeries?
I think that what we're seeing in surgery is a great growth in the utilization of robotic assisted surgeries. I think that initially there was a learning curve for the surgeon in order to be able to perform the surgery in a smaller area, because you don't have that huge incision and the retraction, to be able to perform it safely and to get competent with using the robot. But now what I'm seeing is that the majority of the time, the robot is utilized more often than an open surgery. Of course, anytime there's uncontrolled bleeding, anytime they're unable to really visualize the surgical field well, they may start out robotically and then go to an open procedure. But certainly I'm seeing them starting the cases and scheduling them as robotic or robotic assisted.
Would you say that there are drawbacks to robotic surgeries?
Well, I think the biggest drawback that we've seen, and it's more in the community, not so much in the comprehensive cancer centers, but has been the cost of facilities purchasing a robot. These robots cost millions of dollars, and the setup for each case can be $10,000 for the different equipment that is used during that case. So there is a cost, as well as just the initial cost of buying. There's an ongoing cost for the robot. So I think that's why a lot of community settings have been slower to start to do robotic assisted and robotic surgeries. I just think that robotic assisted surgery continues to really grow. And I don't think we've reached the full potential of what surgeons can do with the surgeries. there is a great learning curve for these surgical oncologists. They're saying that they need to perform around 200 surgeries before they're very confident. And I've seen where when we started going to robotic assisted surgeries, how the surgical times would be longer with the robotic surgery than if it had been an open case. But now through proficiency, we're seeing the cases shorter or the same time as a traditional open surgery. So I think the cost as well as training. And I want to mention here that we're not just, when I'm talking about surgical oncologists, there are surgical oncology nurses in our operating rooms. And one of the things that our surgical oncology nurses do in the OR is they're the ones that help set up the robot and manipulate the robot. And if there's trouble in the OR, they're the ones that troubleshoot the robot too. So there's a learning curve there for our surgical oncology nurses too.
Excellent. Well, that really leads into my next question, talking about surgical oncology nurses. Can you talk a little bit about how the oncology nurse and the surgical oncology nurse collaborate to provide care?
That's a misconception because they are surgical oncology nurses. So these are nurses that are trained in post-operative care, preoperative care, and for nurses that are in the OR, perioperative nursing, as well as oncology. So they have to be competent not only in surgical care, but in oncology care too. So it's a specialty that is within ONS. We used to have a very strong community within ONS when we still had our SIGs and communities that had their own following. But it's very difficult sometimes to go to conferences and to be able to hit this specialty within oncology nursing because it is very different than a medical oncology nurse or a hematology nurse who is mainly giving chemotherapies, CAR Ts, immunotherapies. The surgical oncology nurse needs to understand what chemotherapies and treatments, radiation therapy, anything like that has been done with that patient, because that will certainly impact that patient's outcome, but also to understand the whole surgical process.
Yeah, that is a lot. And, we talk about with oncology nurses, all the different things that they have to understand and all the different treatments. And, this is kind of that added piece with those surgical oncology nurses that are adding on one more thing to understand and to be able to help care for the patients that they have. That's a really good point and something to think about for those nurses. One of the things that we have some podcasts on are onc emergencies. And I wanted to ask you, are there any specific oncologic emergencies that might require surgical intervention? So this is kind of separate from an actual cancer diagnosis, but more related to an oncology emergency.
There are actually surgical oncology emergencies, and I have written about those, and I kind of talked about them during our conversation. A malignant bowel obstruction is certainly a surgical oncology emergency because when that bowel is obstructed, if the obstruction is not relieved, the bowel can dilate to a very enormous size and then literally perforate from all the pressure within the bowel itself. So it's very important, if we can't decompress the bowel, that there is usually an ostomy or something created to relieve the malignant bowel obstruction. The other thing, and I kind of alluded to this earlier, is being aware of what kind of treatments that patients may receive in the medical oncology setting. For instance, bevacizumab is well known to cause bleeding, being a VEGF, and also bowel perforation. So someone who's undergoing treatment with bevacizumab may all of a sudden develop excruciating abdominal pain, nausea, vomiting, come into the emergency room, and on imaging, it will be noted that they have free air in the abdomen. Free air in the abdomen is a surgical emergency. And so that requires the patient going to the operating room and exploring to see where the perforation is and usually resecting that area of bowel that has been perforated.
So, Lisa, I just want to thank you for being with me today and just again for your passion for this topic. And like you mentioned, sometimes this specialty area in oncology you don't hear a lot about. And it's really good for our listeners who are new nurses to oncology or new graduates coming into an oncology area to start to understand what some of the different specialty areas are within the oncology field. As we're coming to the end of our conversation, I just wanted to ask you a couple of questions that I end all of my recordings with. So, the first one that I have for you is what are common misconceptions about surgical interventions for patients with cancer?
I think the most common misconceptions are that having surgery will cure your cancer. Cancer is a very complex disease process. And certainly, I think that as surgical oncology, as a specialty, that is certainly our goal. But curing cancer is not just cutting the cancer out. It also requires radiation treatment, also requires chemotherapy or other new therapies that have been developed like immunotherapy.
What is something about surgery for patients with cancer that's not often discussed, but you wish people knew more about?
I think that patients need to understand that immediate surgery is not always the answer, that preparing for a successful surgery is our goal. And a lot of times I'm taking care of patients who are upset that they're sent home on TPN to get their nutrition in a better place so they can be successfully treated with surgery and have a good outcome. I think people need to understand that the whole surgical process can take place over weeks or months and not necessarily just see a surgical oncologist and having surgery, but working with surgical oncology nurses, physical therapists, occupational therapists, respiratory therapists, and even other medical specialties like cardiology and endocrinology to optimize the patient. That's in the patient's best interest, not just cutting something out.
What additional training or education do oncology nurses need when it comes to surgical intervention for patients with cancer?
That is something that is very difficult, I think, for the surgical oncology nurse. I think it's because there are not a lot of continuing education out there on specifically surgical oncology. I do believe that surgical oncology nurses need to be well rounded and certainly need to be up to date on all the new therapies that we're using to treat cancer. But it is difficult for them to find specifically surgical oncology education. I do think ONS has done a great job with publishing resources for the surgical oncology nurse. ONS has a surgical oncology book that is specifically for surgical oncology and touches every different solid tumor that can be addressed in the surgical process. There's also a specific GI cancer book that talks again a lot about surgical interventions for GI cancers. And most recently, the third edition, Oncology Basics, is going to be coming out, I believe, late this year with ONS. And that has chapters in there on surgery as well as other different treatments for cancers.
And what are some additional resources, whether that would be for patients or providers who want to learn more about surgical oncology?
I think I talked a little bit about those previously. Certainly, any kind of journals, the Clinical Journal of Oncology Nursing, CJON, often publishes different papers on surgical oncology. Certainly, conferences that may be related to your area of specialty within surgical oncology, and certainly podcasts and things like that that ONS offers for oncology nurses.
How about for patients? Is there somewhere specific that you would recommend that patients learn about surgical interventions that might happen for a cancer diagnosis or even prehabilitation? Is there anything you could recommend?
I think anything that's published by the National Institutes of Health or the National Comprehensive Cancer Network is a great resource for patients and families. It certainly gives them correct information on oncology treatments. And certainly any local cancer society, I think, would be able to provide them with good information. There are also different support groups depending on the kind of cancers that you have. Breast cancer support groups, pancreatic cancer support groups, things like that. And those usually are run by surgical oncology nurses that can give patients and family members accurate information.
Okay. Well, again, Lisa, I just want to thank you for taking the time with me today and talking about something that clearly is near and dear to your heart and something that you just really enjoy. Lastly, just do you have any final comments for us?
Stephanie, I want to thank you and ONS for giving me the opportunity today to talk about, again, one of my passions, surgical oncology. I feel like we need to have better education for our nurses. And if I can help in any way by doing this podcast with you, I feel very grateful.
Thank you, Lisa. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.